So you want to own a hospital. And I don't mean work at one or just visit one. I mean you literally want to own one. Well, welcome to this explainer, where we're going to break down what is absolutely the ultimate business paradox of the American healthcare system.
I mean, we've all heard the stories, right? A hospital charging someone $25 for a single Tylenol pill. It sounds crazy. But then, on the flip side, you've probably also heard that most hospitals are technically nonprofits, running on these razor-thin margins and basically just one bad year away from total bankruptcy. Here's the wild part. Both of those things are actually true at the exact same time. So, which is it? Is owning a hospital a guaranteed money-printing machine? Or is it literally one of the most financially brutal businesses you could ever possibly get into? Okay, let's dive into this and open the books.
Before we start talking numbers, we kind of need to clarify what kind of hospital we're even talking about here, because there are three main ownership models in the US. First, you've got for-profit, which basically operates just like a standard corporation. It has shareholders and it pays taxes. Then you have nonprofit, which actually makes up the vast majority of private community hospitals. They reinvest any surplus right back into the facility or the community to keep their tax-exempt status. And finally, government-owned hospitals. These are your state or county-run safety net facilities. They run the absolute tightest margins of all because, well, they simply cannot turn anyone away. Now, to really unpack the underlying mechanics of this business, we're going to focus on the for-profit model, mostly because that's where ownership in the traditional corporate sense actually applies.
Okay, Section 1, the $500 million launch. Let's look at the staggering barriers to entry if you wanted to build a mid-sized 150 to 200 bed facility totally from scratch.
You see, you don't just open a hospital overnight. You are facing a grueling, multi-step timeline. Land and construction, acquiring all the medical equipment, navigating the maze of licensing and approvals, and finally, staffing the launch. Honestly, massive amounts of cash are going to bleed out for months, sometimes even years, before you ever treat a single patient.
Starting with step 1, building a hospital is absolutely nothing like throwing up a typical office block. You're dealing with incredibly strict building codes. Think about it. You need highly specialized HVAC systems for infection control. You need entirely redundant power systems because, let's face it, you absolutely cannot have the lights go out in the middle of a surgery. Plus, you need reinforced structural loads just to hold up the massively heavy medical equipment. All these specialized infrastructure requirements, they easily push construction alone into the hundreds of millions of dollars. And remember, that's just for an empty building. Now you have to actually equip it. The brutal reality of medical equipment costs is that a single MRI machine can cost well over $1 million. CT scanners easily hit 6 figures. Every single operating room needs to be completely fully equipped, and these days that often means including highly expensive surgical robotics if you want to stay competitive. By the time you supply the ICU, the laboratory, and the pharmacy, that easily becomes a staggering 9-figure line item all on its own. When you add in the multi-year process of getting a certificate of need from the government and hiring your entire core staff of physicians and nurses way before opening day, you hit this number, $500 million. That is the staggering $500 million price tag required just to get the doors open. And honestly, this brilliantly illustrates why almost nobody builds a hospital from the ground up anymore. It's just too much. Most owners simply acquire existing facilities instead.
All right, moving to Section 2, the monthly financial bleed. Because once those doors are finally open, the real operational reality sets in.
The most fascinating part of a hospital's monthly cash bleed is how incredibly dominant labor is. A massive 52% of your expenses goes strictly to labor. That's your nurses, physicians, technicians, and administrative staff. Supplies and pharmaceuticals take up about 15%, and the remaining 33% goes to facility maintenance, utilities, and administrative overhead. And keep in mind, a hospital runs 24/7, 365 days a year. There's literally no closing time to save on the electric bill.
So the absolutely crucial point here is that labor basically dictates your financial health. When a hospital is struggling financially, 9 times out of 10, it is due to this, the inflation of labor costs. Nursing shortages have forced hospitals to lean heavily on highly expensive contract and travel labor, paying massive premiums over their standard staff rates. And that severely crushes operating margins.
Which brings us to Section 3, the complex revenue engine. Let's shift gears to how a hospital actually gets paid, which introduces one of the most bizarre pricing models in literally any industry. See, a hospital doesn't just have one customer paying one flat price. You're dealing with entirely disparate payers for the exact same procedure. Commercial insurance pays the highest negotiated rates. Financially speaking, these are your most desirable patients. Then you have Medicare for seniors, which sets payment rates by law that frequently fall completely below the actual cost of care. Medicaid for low-income patients does the exact same thing. Finally, self-pay is the smallest pool, but it's the absolute hardest to actually collect on. Because government programs frequently force the hospital to essentially take a loss, they have to make that money up somewhere else.
And this dynamic is the origin of the infamous charge master. This is the hospital's internal retail price list. It is set artificially high, which totally explains that $25 Tylenol we talked about earlier, but it basically acts purely as a negotiating anchor to offset those below-cost government payouts. Almost nobody actually pays the sticker price you see on a charge master bill.
Because keeping inpatient beds up and running is just so incredibly expensive, savvy hospital systems focus intensely on secondary, highly profitable revenue streams. We're talking about outpatient services and same-day surgeries, specialized service lines like cardiac or orthopedic care, and even real estate, like leasing out space on campus to pharmacies and independent labs. These are the fast-growing engines that actually keep the whole enterprise solvent.
All right. Section 4. The real profit margins. So, after balancing those massive revenues against those absolutely brutal fixed expenses, what does the bottom line actually look like?
Prepare yourselves for this one. The national median hospital margin sits at a puny 4.5%. Contrast that to a typical software company, which can easily run 30% margins. This just highlights how incredibly tight and unforgiving the hospital business really is compared to almost anything else out there.
So, the most crucial takeaway really comes down to this one phrase: your payer mix determines your fate. Your survival as an owner is dictated entirely by the demographics and the insurance status of your local population. It's really that simple.
To put it in perspective, a hospital located in an affluent suburb with a high volume of commercially insured patients, that can be wildly profitable. But the exact same facility, offering the exact same services in a low-income rural area that is heavily dependent on Medicare and Medicaid, it's going to lose money every single year. This geographical reality explains exactly why for-profit owners and private equity firms aggressively shift their investments toward wealthier areas and higher margin specialties.
Finally, Section 5. The risks of ownership. As we wrap up this teardown, we have to look at the uncontrollable external threats to this business.
Even if you do everything perfectly, you still face daunting risks. You've got a heavy, constantly shifting regulatory environment where a single rule change can slash your revenue literally overnight. You have massive malpractice liability exposure, where just one medical error can be financially devastating. You're entirely dependent on a highly specialized, licensed workforce that you can't easily replace. You are incredibly vulnerable to local demographic shifts, like imagine a major employer leaving town and taking all those great commercial insurance plans with them. And on top of all that, there's a constant need for massive capital reinvestment just to keep your equipment up to date and accredited.
Ultimately, owning a hospital is for sure not a get-rich-quick scheme. It is an unglamorous, super capital-heavy infrastructure play built entirely on scale, negotiating leverage, and just extreme operational discipline.
Which brings us to the end of this explainer. You've seen the $500 million startup costs. You've seen the tiny 4.5% margins. You've seen the bizarre negotiating mechanics of the charge master. So, I'll leave you with this. Knowing the razor-thin reality and the immense unyielding costs required to run these mega facilities, what is the true price of keeping our healthcare infrastructure alive? It certainly forces you to rethink everything you thought you knew about the economics of American healthcare. Thanks for joining me to open the books on this topic, and keep asking the big questions.